celecoxib history. The Precision Ambulatory Blood Pressure Measurement Trial, a pre-specified sub-study of Precision, which prospectively examined the cardiovascular safety of long-term celecoxib use in arthritis patients with or at increased risk of cardiovascular disease. Precision ABPM was designed to look at the differential effects on blood pressure with celecoxib versus naproxen and ibuprofen. NSAIDs are useful for the symptomatic treatment of patients with osteoarthritis and rheumatoid arthritis. However, both non-selective and COX-2 selective NSAIDs have been shown to increase blood pressure or interfere with blood pressure control. "545 patients were randomized to receive celecoxib, ibuprofen, or naproxen. Patients had osteoarthritis or rheumatoid arthritis and required daily NSAID treatment to maintain their quality of life. In total, 444 patients had successful baseline and post-baseline visits at months 2 and 4. The two non-selective NSAIDs, naproxen and ibuprofen, were used at prescription strength. Baseline patient characteristics were similar among the three treatment groups. The mean age was 62 years, and the majority were women with osteoarthritis. Average baseline blood pressure was 125/74. And over half the patients were taking multiple concomitant antihypertensive therapies. A high majority of patients completed month 4 of the study. The primary endpoint was the change from baseline in 24-hour mean systolic blood pressure at month 4. Celecoxib demonstrated a mean change in systolic blood pressure of minus 0.3 millimeters of mercury from baseline, and naproxen showed a change of 1.6 millimeters of mercury, both of which were not significant. Yet ibuprofen had a statistically significant change with a mean increase of 3.7 millimeters of mercury at month 4. The mean reduction in the celecoxib group contributed to a significant difference of minus 3.9 millimeters of mercury between celecoxib and ibuprofen. There were no significant differences noted in the pairwise comparisons between celecoxib and naproxen, or naproxen and ibuprofen. Additionally, a post-hoc subgroup analysis was carried out to investigate the proportion of baseline normotensive patients who became hypertensive during the course of the study. Celecoxib demonstrated a significantly lower proportion of patients with new onset hypertension at month 4 compared with ibuprofen and naproxen. Since over 40% of patients with osteoarthritis also have hypertension, even small differences in blood pressure may impact cardiovascular morbidity and mortality. Precision ABPM broadens our understanding of the risks associated with NSAID use in arthritis patients with or at increased risk for cardiovascular disease.
Good afternoon. Welcome to the 18th Lourdes Manahan Lectures in Rheumatology. This is an annual lecture series spearheaded by the Division of Rheumatology, University of the Philippines in Manila. I'm Dr. Jose Paulo Lorenzo, a clinical associate professor of medicine from the Division of Rheumatology, and I will be moderating this session. I would like to thank our sponsor, Viatris, for your support of this webinar, and I'd like to thank everyone, all the participants, for joining us today. If you have any questions, please type them in the Q&A box, and we will read them out during the open forum after the lecture. You will receive your certificate of participation to this webinar through your emails a week after you submit the evaluation form and the post-test. The link will be posted in the Q&A box and at the chat box midway through the webinar. The LMLR is an annual event hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. The first lecture for this year will focus on lupus, an apt topic for this month of May, as it is also the Lupus Awareness Month. Our speaker is a clinical professor at the UP College of Medicine and an active consultant at the St. Luke's BGC and Manila Doctors Hospital. Her work on lupus started during her fellowship training here in the PGH and continued on during research fellowship in Cedars Sinai Medical Center in Los Angeles, California. Aside from her research, she has also dedicated part of her time as the vice president of the Hope for Lupus Foundation. Let us welcome Dr. Geraldine Zamora to discuss dilemmas that our patients with SLE face beyond disease activity. Dr. Zamora.
Good afternoon, Dr. Lorenzo, and thank you for the introduction. Let me just share my screen. There you go. Good noon, everybody. Thank you for spending your lunchtime with us in the Division of Rheumatology of PGH. These are my disclosures, but they are not in relation to this particular talk. So in 2018, Selena Gomez shocked her hundreds of millions of followers by posting this photo. She had undergone kidney transplant because hers were already damaged by lupus. Since then, the word lupus has begun to circulate and come into the working vocabulary of people, especially among the young. If you would look at her now, she's still thriving. She continued to release albums, and I think she's even in a cooking show or has her own cooking show. But for our patients with lupus who look this well and this beautiful, she does seem to have some pushings on her face. So do we stop at lupus activity? Is it our only concern? My objectives for the next 40 minutes as assigned to me is I would like to have my audience recognize the medical problems associated with SLE other than disease activity, including musculoskeletal pain arising from a vascular hip necrosis or vascular necrosis in general and fibromyalgia, and invisible issues including cardiovascular disease and mental health disorders, as well as to discuss the appropriate approach in the management of these problems. SLE is a chronic, autoimmune, inflammatory, and multi-system condition that affects virtually any organ of the body. Patients present with variable clinical features ranging from mild joint pain and skin involvement to life-threatening renal, hematologic, and even brain or central nervous system involvement. Worldwide incidence and prevalence estimates of lupus vary substantially. The highest prevalence is in African American and Afro-Caribbean women, and lowest prevalence is in white men. In this figure, the prevalence is shown in ranges per country per 100,000 of the population. In Asia, prevalence rates usually fall within 30 to 50 per 100,000 population. And most likely due to improved detection of mild diseases, incidence has tripled in the last 40 years of the 20th century. Lupus is more frequent in women, and in 9 of 10 patients with lupus are women of childbearing years, with 65% of patients having disease onset between ages of 16 and 65, or rather 55. So it is a very special population. They're productive members of the society. They're mothers, they're sisters. Hence, all the more important that we help them manage their conditions the best way possible. Do note that patients or people outside this age range, whether younger or older, can still have SLE, but the female to male ratio can be as high as 15 to 1 in adults. Immune system activation in SLE is characterized by exaggerated T and B cell responses and loss of immune tolerance against self-antigens, production and defective elimination of antibodies, circulation and tissue deposition of immune complexes, and cytokine activation contribute to clinical manifestations that range from fatigue to life-threatening organ damage. This is one of the more recent classification criteria of SLE with an entry criterion of at least 1 to 80 of ANA or anti-nuclear antibody, and at least a score of 10 is needed for a patient to be classified as having lupus. There is no cure for SLE, much like many other chronic conditions, but we can help patients manage them so they live a normal life. Complete sustained remissions are rare, but the goals of therapy for patients with SLE are to ensure long-term survival, achieve the lowest possible disease activity, prevent organ damage, minimize drug toxicity, improve quality of life, and education of patients about their role in disease management. Patients require monitoring at regular intervals by a rheumatologist to optimize both non-drug and drug therapies and achieve treatment goals. Patients often have multi-organ system involvement and may require disciplinary care. And this is just an algorithm for the pharmacologic part, wherein patients are initially categorized to have either none or life or non-life or organ-threatening manifestations, wherein management rather is more conservative versus life or organ-threatening illness. For prognosis, lupus is marked by disease remissions and relapses. The 5-year survival rate has dramatically increased to greater than 90% since 1980s. But despite this, the major cause of death in the first few years of illness are active disease or infection due to immunosuppression, while causes of late death include complications of lupus, treatment complications, and cardiovascular disease. So since we're already on the subject, let's put a focus on cardiovascular disease in SLE. We all know that SLE is associated with increased risk of accelerated atherosclerosis and cardiovascular events, including coronary artery disease, cerebrovascular disease, and peripheral artery disease. Cardiovascular events occur both early and late during the disease course, with younger patients being at much higher risk than age-matched counterparts. And this risk cannot be fully accounted for by the increased prevalence of traditional atherosclerotic factors and may be due to type 1 interferons and other inflammatory cytokines, oxidative stress, production of antiphospholipid and other autoantibodies causing dysfunction of lipoproteins, altogether resulting in endothelial injury and pro-atherogenic dyslipidemia. This medication or these mechanisms may further be aggravated by chronic intake of medications such as prednisone, even at doses less than 7.5 milligrams per day. The reported risk of myocardial infarction or heart attack in patients with lupus ranges from 2 to 10-fold greater than the general population, with a peak of 50-fold reported in women between age 35 to 44 years. Relative risk values include 10 for non-fatal MI, 17 for death due to ischemic heart disease, and about 8 for stroke. These data are particularly striking given that the majority of patients are female and that 67% present with their first event before 55 years of age, so very young. Factors linked to the incidence of cardiovascular disease include disease duration, clinical activity, the titer of anti-dsDNA, presence of lupus nephritis, and steroid use. So the more of these factors, the higher the incidence of cardiovascular disease in these patients. On the left are traditional risk factors for cardiovascular disease. We all know this already: dyslipidemia, smoking, hypertension, inactivity, insulin resistance, and obesity. And note that although rheumatoid arthritis and lupus predispose to premature atherosclerosis, the pathogenic mechanisms differ. And while TNF alpha, IL-1, and IL-6 play a central role in RA pathogenesis, type 1 interferons predominate in SLE. This is a local cross-sectional study of 50 patients done in 2011, so this was still 10 years ago, to determine the prevalence of traditional and non-traditional risk factors, ECG changes, and risk factor screening procedures among lupus patients at the Philippine General Hospital. All were female with a mean age of 29 years at diagnosis. And among risk factors screened, those of the highest prevalence were dyslipidemia at 82%, hypertension 38%, and obesity at 11%, generally comparable to those of the general population reported in literature. And although I failed to add it in this slide, the paper concluded that there is less than adequate monitoring of cardiovascular risk factors, and that only 1/3 of patients had measurements of their height and weight to check for their BMI, and only about 1/2 had fasting blood sugar and lipid profile tests on their first few consults. So it's something we can improve on. Despite the increased risk, the relatively modest absolute numbers of cardiovascular events in lupus present a challenge, hence the need to rely on biomarkers of disease activity or burden. So cardiac PET scan revealed impaired microvascular blood flow and reduced coronary flow reserve following adenosine challenge in lupus patients with angiographically normal appearing epicardial arteries. Single photon emission tomography demonstrated myocardial perfusion defects in 40% of lupus patients. And carotid artery ultrasound revealed a marked increase in early plaque in patients with lupus, and the plaque burden appeared related to SLE activity. So these non-invasive biomarkers of arterial abnormality generally indicate future cardiovascular events in non-lupus patients, but require further validation in this regard in patients with lupus. Management of cardiovascular disease will depend on various cardiovascular manifestations and underlying pathology driving the disease. This table shows us how to manage traditional risk factors present in our patients. So we all know this already. We may give hypoglycemic drugs, antihypertensives, statins, advise smoking cessation, even advise approved medications and surgery for obesity. And these do not differ among those without lupus. And this table shows SLE specific risk factors and their interventions. We see a lot of lupus factors being managed by immunomodulatory drugs, especially hydroxychloroquine, because these may exert anti-atherogenic properties. And because it's too broad to discuss for this particular webinar, you may refer to this article to cross-check references and specifics. But I was particularly interested in N-acetylcysteine here for oxidative stress because it's readily available in the country. I searched for more literature and found a systematic review of 30 papers wherein the authors summarized findings about NAC, which is an antioxidant. And it appears that NAC has been shown to be potentially beneficial to lupus patients with a favorable side effect profile because it improved endothelial dysfunction and decreased CRP. And we know that high CRP correlates with cardiovascular diseases. Non-pharmacologic measures in reducing cardiovascular disease in lupus patients include consuming food with low glycemic index, with low caloric index, and these significantly reduces weight, also improves fatigue, as well as hip and waist circumference. Exercise, which has been found to improve this endothelial dysfunction and aerobic capacity. Smoking cessation is important, counseling. This paper talked about an RCT, wherein omega-3 PUFA or polyunsaturated fatty acid supplementation in SLE patients who do not have traditional risk factors for coronary artery disease and also not on prednisone have shown significant improvement in endothelial dysfunction, disease activity, and reduction of oxidative stress. I tried to look for higher level study regarding this because it's one of the supplements patients have been asking us, and found this meta-analysis of 5 studies published just December last year. And the authors estimated that the effect of omega-3 fatty acids on lupus disease activity in adults, with all the studies using less than 3 grams of omega-3 fatty acids per day. It suggests that these could provide therapeutic benefit by decreasing disease activity in addition to immunosuppression used for lupus. And while it's not directly linked to improvement of cardiovascular risk profiles, it may be something useful in the management of our patients. To date, there is a paucity of randomized studies regarding the effectiveness of preventive strategies and pharmacologic interventions, specifically in people with lupus. Nevertheless, recommendations emphasize that patients with lupus should undergo regular monitoring for atherosclerotic risk factors and calculation of the 10-year cardiovascular risk. Risk stratification should be done, prescribing low-dose aspirin in selected cases, as well as lupus-specific management, such as control of disease activity, decrease in steroids if possible, and use of hydroxychloroquine should be done for our patients with lupus. And further studies will be required regarding use of the biomarkers, as I mentioned earlier. So now we proceed with vascular necrosis, because although there has been significant improvement in patient survival rates for decades, the past decades, the adequate management of cumulative organ damage remains to be solved. Hippocrates first described the concept of bone death and the first description of osteonecrosis. It now refers to regional death of the cellular elements of bone, typically in a subchondral location, which leads to trabecular and subchondral collapse. So in its simplest characterization, focal bone death results from compromised arterial blood supply, leading to reactive hyperemia of adjacent bone, demineralization, and then collapse. There are several speculations about processes that could compromise bone health, and these include altered fat metabolism, wherein increases in the amount of fat within the femoral head elevate intracortical pressure and lead to sinusoidal collapse. Studies in rabbits have confirmed that steroids increase the fat content of the femoral head, and that this increase correlates with an increase in intraosseous pressure and decreased blood supply. Another mechanism is intravascular coagulation of the intraosseous microcirculation, progressing to more generalized thrombosis. And as a non-distendable structure with a cortical shell, bone has limited capacity to accommodate an increase in space occupied within. So any change may elevate intracortical pressure and compromise blood flow. Recurrent intramedullary hemorrhage may contribute to the pathogenesis, and toxic accumulation of lipid droplets within the bone cells occur with high-dose steroids and alcohol, and can damage the cell membranes and lead to cell death. So AVN has been linked to numerous conditions such as steroid and alcohol use, trauma, use of bisphosphonates, and in conditions such as lupus. So in SLE, the musculoskeletal system involvement is cumulative over time and at very high frequency, and AVN accounts for a large portion of this involvement. It often causes serious consequences such as disability and lower quality of life. So this is usually bilateral and asymptomatic, but AVN of the femoral head should be suspected in a patient with lupus who has groin pain that is worsened with weight bearing and movement of the hip. There is pain that may radiate down on the side of the thigh, as in this photo, and a limp might be evident. However, it may be quiet at rest, and it may be present at rest, and then it may even be asymptomatic, especially when it's still confined to the medullary bone. AVN in patients with lupus is most common in the femoral head, although the humeral head, the tibial plateau, and scaphoid navicular can also be affected. The wrist and hand bones, the vertebrae, and the facial bones may also be affected, but less commonly. Osteonecrosis often develops a relatively short time after the onset of steroid therapy, within the first 3 months of initiation of high-dose steroids. So it's good to note that patients who had no MRI abnormalities in the femoral head during the first year of follow-up were unlikely to develop osteonecrosis at a later date. In this meta-analysis of 62 articles to determine the prevalence of and risk factors of AVN in patients with lupus, prevalence of symptomatic AVN was 9% in lupus and 29% for asymptomatic AVN. I could not retrieve the full text of this article even in Sci-Hub, so I just summarized the results in the abstract into this table. So these on the left were found to be associated with AVN. So those are high-dose steroids and their side effects, including hypertension, Cushing's, but not diabetes and hyperlipidemia. Associated also is active lupus, so that's cutaneous, vasculitis, renal, neuropsychiatric manifestations, serositis, cytopenia, Sjogren syndrome, Raynaud's phenomenon, arthritis, cyclophosphamide, but not azathioprine, MMF, or methotrexate in this meta-analysis. More damage is associated with AVN except for musculoskeletal system damage. Autoantibodies and other immunologic markers did not predispose to AVN except for IgM and anticardiolipin seen in APAS. So this doubles the risk of AVN in our patients. So in this particular meta-analysis, it was found that the mean daily dose of steroid and duration of steroid had no impact on AVN occurrence. However, in this article, published a year later after that meta-analysis, found that after adjusting for age, sex, and disease duration, total cumulative corticosteroid dose more than 20 grams and use of immunosuppressants were significantly associated with AVN. Okay, so very high odds ratio here, 3 to 8. And for this study, for this study, mycophenolate is already included and has an odds ratio of 4.5, increases the risk for AVN. So a new meta-analysis might be good to do following these papers. The authors of this paper evaluated whether there was an interaction between steroid dose and immunosuppressants on the development of AVN. And when the patients with a total cumulative dose less than 20 grams and no use of immunosuppressants were defined as a reference, the odds ratio for total cumulative dose greater than 20 grams was 3, and for use of immunosuppressants was 4.3, and for both factors was 15, suggesting both associated factors increased the risk of AVN independently and, more importantly, synergistically. However, AVN can also occur in patients who have not used steroids. Furthermore, the incidence of AVN was found to be higher in patients with SLE than non-SLE patients requiring steroid therapy, supporting the roles of several factors specific to lupus. So this is an algorithm for the diagnosis of AVN. A high index of suspicion is crucial. Pain is usually the presenting symptom, but the disease may be quite advanced by the time patients present with pain, especially when the progression is insidious. So in addition to obtaining a complete history, including identification of potential risk factors, a complete examination of the affected joint must be performed. Examination should include direct observation for any obvious abnormalities, such as leg length discrepancy or mass, or any abnormal orientation of the extremities. And when a diagnosis is suspected, it can be confirmed either by imaging studies or arthroscopy. So we refer to orthopedics. Note that most lesions on plain X-rays develop only 4 to 7 years after the diagnosis of lupus. And this is usually due to late diagnosis. In the early stages of osteonecrosis, plain radiographs are typically normal. The earliest radiographic change include diffuse osteopenia and linear sclerosis, typically adjacent to the joint margins. Later, the subchondral radiolucency seen in this photo can organize into a crescent sign, and appearance is pathognomonic for AVN. Later changes include flattening of the articular surface and sometimes gross collapse. Initially, the joint space is normal, but later on develops secondary osteoarthritis. So we see increased density of the femoral head, loss of the normal spherical shape, and as mentioned, flattening of the superior aspect. This is the FICAT or FICAT and Arlett staging using radiographs. Stage 1 is normal. Stage 2 would show sclerotic and cystic lesions. Stage 3 would show subchondral collapse. And 4 would be osteoarthritic with joint collapse. MRI has become the gold standard for imaging of osteonecrosis or AVN because it is more sensitive and is able to detect bone marrow edema, which is an early feature of osteonecrosis. Typical MRI findings are intermediate or low signal intensity on T1 weighted images and then high signal on T2 weighted images. In advanced osteonecrosis, however, the necrotic segment exhibits low signal intensity both on T1 and T2 weighted images. If collapse is identified and immediate surgery is contemplated, the American College of Rheumatology recommends MRI to evaluate for occult AVN also of the contralateral hip. But a caveat of this is MRI studies may be too sensitive as an indicator in that some patients with lupus suggestive MRI findings may never progress to clinical symptoms of osteonecrosis. Therefore, MRI, as with any lab testing, should always be interpreted in the context of the clinical setting. Treatment of non-traumatic osteonecrosis remains one of the most controversial subjects in orthopedic literature. If the osteonecrosis is caught in the early stage, the goal of therapy is to preserve the native joint for as long as possible. However, given that hip AVN often progresses, the mainstay of treatment is surgical, using either a joint-preserving procedure if possible, or total hip replacement or arthroplasty. So this is just an algorithm of treatment consisting of conservative and surgical treatment. Conservative approaches are advocated for when the affected segment involves less than 15% of the joint margin and is remote from the weight-bearing region. It's prudent to inform our patients or to advise them to avoid risk factors such as steroid use, kung kaya, because some patients self-medicate after a while, and avoid weight-bearing on the affected side for the meantime. There is a long-standing view that the affected region should be offloaded for about 1 to 2 months. Crutches can be prescribed in order to accomplish this. However, conservative approaches do not influence the outcome and do not prevent disease progression, maybe just delay but not prevent. Medical treatments are also limited in scope. Other suggested interventions include physical therapy to maintain muscle strength, and use of analgesics and NSAIDs judiciously to help relieve pain. And a critical management decision eventually would be to do surgery or when to do surgery and which to employ. So this will just be a very quick rundown of surgical procedures that patients with AVN might have to go through. So, overall, surgically treated joints generally have better outcomes. So these could be joint preservations, such as core decompression and variance. So this is a figure for that or an illustration of that. Bone grafting can be vascularized or non-vascularized, and osteotomies may be done. So this is just a few slides on that. So this is just structural bone grafting, while vascularized bone grafting includes a pedicle, a vascular pedicle to attach to another blood supply to improve blood flow. Osteotomies are not very much done now because long-term outcome data are scarce. Hip replacement is the treatment of choice. One could be just resurfacing arthroplasty, but a downside to it is possibly increased metal ion levels. It could just be a hemiarthroplasty, so it could be unipolar or bipolar, or usually patients will have to go through total hip replacement, complete replacement of both the joint on the femoral side as well as the acetabular side. So compared to cemented total hip replacements done for other conditions, AVN had a greater risk for loosening of the components, and at 10 years, or at 20 years rather, only about 64% of these joint replacements are still viable and may have to be replaced. Investigational therapies and interventions that have been used but are not proven or reliably used to treat AVN include bisphosphonates, because these are thought of as therapies that can slow bone resorption of necrotic areas. Statin therapy, anticoagulation have been used to prevent progression, possibly related to thrombophilia. Vasodilators may decrease intraosseous hypertension and increase blood flow to ischemic areas of the osteonecrotic lesions. Extracorporeal shockwave therapy is thought to promote bone healing through stimulation of neovascularization. Electrical or electromagnetic stimulation may stimulate osteogenesis, and hyperbaric oxygenation may increase oxygen early in the ischemic phase. So these agents are not likely to be used on a daily basis, and they need further studies. Regarding anticoagulants, this is a study evaluating 70 patients with lupus who required high-dose steroids, and half of them were given anticoagulation with warfarin. And although the differences were not statistically significant, fewer patients in the warfarin group developed osteonecrosis compared with the control group. But of course, this is something we have to consider based on the profile of the patient. Okay, another source of pain in patients with lupus is fibromyalgia, a syndrome of generalized musculoskeletal pain and tenderness. Fibromyalgia is 6 times more common in women in reports from specialty clinics. And aside from widespread pain, these patients also experience non-restorative sleep, fatigue, cognitive disturbance, psychiatric symptoms, and multiple somatic symptoms such as abdominal pain, irregular bowel movement, and others. Like many other common chronic pain syndromes, fibromyalgia has been a controversial condition since patients look well. There are no obvious abnormalities on physical exam other than widespread soft tissue tenderness, and laboratory and radiologic studies of musculoskeletal structures are normal. However, ongoing research suggests that fibromyalgia is a disorder of pain regulation, often classified as a form of central sensitization, wherein maladaptive amplification of pain signals occur in the CNS. There is decreased threshold for pain, which may be due to disruption of serotonin or norepinephrine neurotransmission in the spinal cord. Hence, the brain perceives allodynia, wherein light touch is painful, and hyperalgesia, wherein painful sensation is even more painful. Various components of the CNS appear to be involved, including the hypothalamic pituitary axis, pain processing pathways, and the autonomic nervous system. The diagnostic evaluation includes a thorough history and physical exam, together with limited laboratory testing to exclude other conditions. The cardinal symptom of fibromyalgia is chronic widespread pain or multi-site pain, MSP, present for at least 3 months, usually with symptoms mentioned in the previous slides. So generally, many soft tissues are very tender with modest palpation and are more tender than the joints. There should be no soft tissue or joint swelling or redness. And while there is still no blood test that can accurately identify fibromyalgia, testing should be kept at the minimum. Frequently, we only need to do a CBC and maybe either an ESR or a CRP to check for inflammation. If there is weakness, maybe we can check the CKs. And if there are signs of hyper or hypothyroidism, we proceed with thyroid testing. Here are just hints for early and cost-effective diagnosis of fibromyalgia. Patients usually say these: I hurt all the time. I feel that I always have the flu. They always have fatigue. They have sleep and mood disturbances. They may have irritable bowel syndrome, irritable bowel. So some patients say they keep on urinating even if they don't drink a lot of water or fluid, and multiple other complaints. So because of the importance of excluding other conditions and recognizing comorbid disorders, clinicians unfamiliar with these disorders may need to refer patients identified by use of such criteria to a clinician familiar with these conditions and with fibromyalgia for confirmation of the diagnosis. So we don't embark on parang a fishing expedition, no? Yung ipapatest na lang lahat, just so we can eliminate everything. It would be very costly for the patient. Okay, so compared with earlier criteria, the 2010 American College of Rheumatology preliminary diagnostic criteria for fibromyalgia do not require a tender point examination, and this is replaced by the widespread pain index and the symptom severity scale, and this has a sensitivity of 88%. In part 1, the WPI measures the number of painful body regions during the past 7 days, with 19 as the maximum score. So this is something even patients can do. They can do the checklist while waiting for us in the clinic or even through teleconsults. No? So it could be shoulder girdle, upper arm, lower arm, buttock pain, leg pain, jaw, chest, abdomen, neck, upper back, lower back. So they just have to say which area is painful on a checklist. And this is part 2, the symptom severity score. So part 2A is asking them regarding fatigue, or if they are waking up unrefreshed, or if they have cognitive symptoms such as maybe poor attention span, memory lapses, and they will answer on a scale of 0 to 3. So it could be no problem, it could be slight or mild problems, moderate or severe. And this is just part 2A, no? So we tally the score for part 2A. And then this is part 2B, wherein it's also a checklist of other symptoms experienced over the past week. So there are a lot of seemingly non-associated and very widespread somatic symptoms. For example, wheezing, there's also loss of taste, painful urination, hives, and many others. So this would be the scoring system. And then when we add the score here with 2A score, we now have an SS score, which can range from 0 to 12. A patient is diagnosed then with fibromyalgia when these are met: a WPI of 7 with SS of 5, or a WPI of 3 to 6 with an SS score of 9. And symptoms have been present for more than 3 months, and there is no other disorder to explain the pain. Which brings us to the occurrence of fibromyalgia in conditions where pain is usually a sign of disease. This is very common in patients with lupus, and literature varies, but up to 40% are said to be experiencing fibromyalgia among patients with lupus. It is a source of many of the symptoms and much of the disability in patients with lupus. But more importantly, the association may pose diagnostic dilemmas because fibromyalgia does not correlate with disease activity, but is strongly correlated with functionality and quality of life, as in the short form 36. In addition, the clinical features of fibromyalgia in these patients may contribute to a misinterpretation of their clinical condition, and the recognition between lupus and fibromyalgia should be something that we will do more practice on. Fibromyalgia and SLE patients share many symptoms. Aside from musculoskeletal pain, they share fatigue, brain fog, headache, and depression. And although not in this photo, these two conditions also manifest with cold-induced vasospasms or Raynaud's, Zika symptoms or dryness of the mucosa, and even cognitive dysfunction. Differentiating between the two can be very tricky and may lead to overtreatment with steroids and immunosuppressants. Therefore, it's important to note certain differences. Fibromyalgia patients may have sensitivity to touch, yung parang mahapdi, or when you just touch them, it's already painful without even putting pressure. This is usually not seen in patients with lupus. Patients with lupus activity will more likely also manifest with fever, with rash, skin lesions, photosensitivity, and especially joint tenderness and swelling. Pain in fibromyalgia patients, usually in the soft tissues only. And we may need to get some lab tests such as the CK to check if there is really myositis, which speaks more of lupus activity rather than fibromyalgia. In this article, the authors sought to establish the performance of cell-bound complement activation products as a diagnostic tool to distinguish fibromyalgia from lupus and found that these distinguish fibromyalgia from SLE. However, this is not yet available in the country, so we have to rely on our expertise and clinical judgment when distinguishing lupus activity from fibromyalgia using available tools and subtle signs from better history and physical exam. There are also conditions which simulate or are concurrent with fibromyalgia that may occur in lupus patients that we may have to exclude because these conditions may manifest the same way but will need different management. Remission or the lowest possible disease activity is the main target in the management of lupus. And the goal in the treatment of fibromyalgia is to minimize symptoms and improve general health in these patients via patient education, pharmacologic and non-pharmacologic therapies. Drug treatment include analgesics. So tramadol in particular is efficacious, both isolated or in fixed dose combination with acetaminophen. There is limited evidence that patients may experience enhanced analgesia when treated with combinations of NSAIDs due to the presence of concurrent peripheral pain conditions such as damage from OA or inflammation from RA or lupus. Pregabalin and gabapentin have the same mechanism of action and bind to the alpha-2 delta subunit of calcium channels. And several studies have already shown efficacy of pregabalin against pain, sleep disturbance, and fatigue compared with placebo in fibromyalgia. And as a result, the pregabalin was the first drug approved in the United States for this condition. Tolerability of these drugs can be enhanced by beginning at a low dose and giving either 2/3 of the dose or the entire dose at bedtime instead of splitting them throughout the day. So the maximal improved dose or approved dose of pregabalin is 450 milligrams per day. But in trials, it was already studied that at dosages of 600 can also be safe and efficacious. The dosage of gabapentin needed for analgesic effect is often 1,800 to 2,400 milligrams per day. Another anti-epileptic compound is clonazepam and has demonstrated ability to decrease pain in TMJ syndromes as well as to address restless leg syndrome in people with fibromyalgia. Moving on to antidepressants, we have tricyclic antidepressants, very effective, particularly amitriptyline in treating symptoms of pain, poor sleep, and fatigue. Tolerability can be a problem, but this can be improved by beginning at a very low nighttime dose. And because of better adverse effect profile, there are already SSRIs such as fluoxetine used in fibromyalgia, as well as duloxetine and milnacipran, which are SNRIs or serotonin norepinephrine reuptake inhibitors. So these drugs have less side effects and are found to be quite effective in treating patients with fibromyalgia. So the maximum dose for duloxetine is at 60 milligrams per day and 100 milligrams per day for milnacipran, although studies as high as 200 milligrams can be, in studies, it has been shown that up to 200 milligrams is pretty safe. It is strongly recommended to avoid opioid narcotic medications for treating fibromyalgia. A variety of neurostimulatory therapies can be effective in treating musculoskeletal pain. This is transcutaneous electrical nerve stimulation, or TENS. The conventional ones are given at high stimulation but low intensity. So pain relief is immediate but short-lived when it occurs. And it could also be acupuncture-like TENS, wherein it's lower in frequency but more intense. May sometimes be uncomfortable for patients, but when it works, it generally has a longer lasting effect than the conventional TENS. A new set of neurostimulatory therapies may be more effective for centralized pain because these therapies all aim to stimulate the central nervous system and then hence modulate CNS pain transmission. These include non-invasive techniques such as transcranial direct current stimulation and repetitive transcranial magnetic stimulation. So I asked and is available in big hospitals such as St. Luke's, but I haven't really tried this on any of my patients with fibromyalgia. So there are also more invasive techniques such as spinal cord stimulation, deep brain stimulation, as well as vagal nerve stimulation, and these have shown promise in patients with refractory pain states. The two best studied non-pharmacologic therapies are cognitive behavioral therapy and exercise, and both efficacious in the treatment of fibromyalgia. Stress management techniques and behavioral training include deep breathing exercises, so it can be as simple as that, meditation, allowing time to relax each day. So we all need that, not just our patients with fibromyalgia. Activity pacing, visual imagery techniques, mindfulness. We hear this word all the time. So mindfulness is a non-spiritual meditation practice that cultivates present moment awareness. Mindfulness-based stress reduction has been shown to significantly improve symptoms of fibromyalgia. Enough sleep helps with fatigue. So we try to promote good sleep for our patients, or good sleep habits rather. So they must go to bed and get up at the same time each day, and maybe limit daytime napping. If they work at night, then make their habits routine. So even if they sleep in the morning, make sure their room is dark, their room is cooler, and all those helpful things to help them sleep better. Exercise may initially increase pain, but regular exercise will gradually decrease symptoms, even analgesic use and antidepressant use. And sometimes we may use the word physical activity better than saying exercise because a lot of people are already allergic to the word exercise. Some exercises we could advocate for include just simply walking around their house, especially during this pandemic. They really cannot go out anyway. Stretching, observance of good posture, breathing, relaxation techniques. Complementary and alternative therapies have been explored by patients managing their own illnesses as well as by healthcare practitioners such as us. So as with other diseases, there are very few controlled trials to advocate for this use of these general non-pharmacologic therapies, trigger point injections, acupuncture, chiropractic manipulation, and myofascial release. These are met with varying levels of success. May not be very easy to do now because of the pandemic and the ECQ and the potential for exposure. So anyway, this last condition I'll be discussing is also frequently seen in lupus patients and is related to fibromyalgia, which I had just discussed. This is quite close to my heart because this study brought me to Cedars-Sinai for my postdoc, where I learned so much more about this multifaceted condition. So anxiety and depression pose serious repercussions, including a four-fold higher odds of vascular disease, increased suicidal ideations, and even mortality. Reported prevalence of mood disorders vary widely from 8 to 47% for anxiety and up to 70% for depression in patients with lupus. And this may be attributed to several factors, including how the diagnosis was approached, the nature of the study, patient genetics, geography, ethnicity. Furthermore, disparities and factors making up the socioeconomic status, including income, education, and occupation, are causes of differences in prevalence of mood disorders. This hospital anxiety and depression scale is a self-administered instrument we can all ask our patients to do, and this is reliable for detecting states of anxiety and depression. It's a very simple tool we can use in the clinics or even through telemedicine to assess the presence of anxiety and depression in our patients. There are 7 questions in each of the subscale, and these are just samples in Filipino. So HADSP is the Filipino version. It's already been validated, and a score of at least 8 on any of the HADSP subscale is suggestive of depression or anxiety. So these are questions, and it's easy to Google a copy. There are 7 per scale. Results of the study we did among lupus patients in PGH show that about half of them had anxiety versus 21% of controls, which were caregivers, and 21% had depression versus 2.6% of the controls. And those who have jobs during lupus or while they or those who have jobs and they have lupus were 4 times less likely to be depressed than those without occupation, and those who were self-supporting, have active disease activity, and who are anxious are more likely to be depressed than those who are not. No? So yung self-supporting here means that they don't have external support and they only have themselves to rely on. When we compared this with a Southern Californian cohort, we found that the prevalence of anxiety symptoms was high in both Southern Californian and Filipino cohorts. Depressive symptoms were twice as high among Southern Californians compared to Filipinos, and only 1/4 of these patients, and none from Manila, were on anxiolytics and antidepressants. So this speaks of undertreatment. Southern Californians were younger and had higher disease activity. They were significantly more anxious, and those without occupation had higher depression scores. These factors, however, were found not to be significant among Filipino patients. Those with lower income were associated with anxiety and depression among Southern Californians. This only applied for depression among Filipinos. And sex, education, health insurance, marital status, and disease duration showed no association with anxiety and depression. On further analysis, it was found that low self-esteem, optimism, coping, and social support were associated with depression, and low self-esteem was associated with anxiety for both groups. Despite the Filipino cohort's lower reserve capacity and socioeconomic status, Filipino patients exhibited less depression than their Southern Californian counterparts, suggesting that other factors may protect them from experiencing depression. A subsequent analysis by my psychology partners showed that patients reported a high level of perceived inability to control one's disease, and that this learned helplessness, I'm not sure if you've already heard of this phrase, fully mediated the relationship between pain and anxiety, depression, as well as perceived stress among people with lupus. Especially now that we're in this pandemic where anxiety has surely been skyrocketing, we have to remember our patients with lupus. So this study by Dr. T, Dr. Salido, and other authors seen in this slide presented the psychological responses of Filipino patients with lupus and rheumatoid arthritis to the COVID-19 pandemic, as well as the shortage of hydroxychloroquine in the beginning of the pandemic. The psychological impact of COVID-19 outbreak was at least moderate in one-fifth of these patients. Stress, anxiety, and depression were moderate to severe in many of the respondents. Risk factors for adverse mental health during the COVID-19 pandemic include presence of comorbidity of hypertension and asthma, being a healthcare worker, of course, and presence of specific symptoms of myalgia, cough, breathing difficulty, dizziness, and sore throat. Siyempre, nakakatakot talaga, di ba, when you have these symptoms. And especially for our patients with lupus, these may compound their already present baseline anxiety and depression. The protective factors for mental health during this pandemic include satisfaction with available health information. So we can help by providing adequate information to our patients whenever they consult. And I know a lot of our lupus groups and societies have been generating health information and posting them online for our patients to see. So this is a very good step towards helping our patients. Wearing a face mask also protective for people's mental health. So if we find that our patients with lupus have anxiety or depression, a consultation with a psychiatrist is highly recommended. We should endeavor to offer them interventions aimed at improving self-esteem and optimism. I also tell my patients to stop looking at Instagram or social media posts that make them feel bad or make them feel like they're not beautiful or that they don't have enough. Life coaching can also be important. It has been working for 2 of my patients. I refer them to a life coach. Self-help books. Many of the treatment for fibromyalgia, such as increasing physical activity, sleeping adequately, are also going to be helpful for our patients with anxiety and depression. And support groups, volunteerism can provide real emotional benefits. Helping with a charitable cause can be meaningful if people can create, social or supportive connections. Diba sabi nga nila, when you help someone else, you forget your own problems more. Okay, so this can have a positive impact on the sense of well-being of our patients. So these are just some of the lupus support groups we can refer our patients to. And if your patient still does not have a rheumatologist and he or she may have lupus, you may refer to this list in the Philippine Rheumatology Association for a list of rheumatologists near your area or your patient's area. Empowering our patient by explaining to them their condition and helping them seek support will do wonders, because as we've seen in the slides I've shown, there's really not a lot of pharmacologic management that we can offer, but we can always offer ourselves and our support. So to conclude, I was actually going to put Selena's photo here, but there might be copyright issues. So the next time we see our patients with lupus such as her, we may need to remember that we need to look out for these other conditions that she might have, not just her malar rash, not just her joint pain, not just her other disease activity measures. So just some more take-home points. Pain in lupus does not always mean disease activity. Symptomatic AVN is the most common type of musculoskeletal damage in lupus. AVN and fibromyalgia may lead to pain and overtreatment of lupus. Cardiovascular disease is one of the most common cause of death and should be managed by identifying potential risk factors, treating dyslipidemia. So we need to do better risk screening. And anxiety and depression must be sought for and addressed properly. We should encourage all our patients to increase their physical activity, even if they're just at home. They can always just walk around the house, or I tell them that whenever they watch their Korean novellas, they should have a liter of bottled water, and then they use it to be active even if they're watching. So good sleep can also help alleviate many of the problems seen in these patients. Timely referral, of course, is warranted to our colleagues in psychiatry, orthopedics, and other specialists as needed. So thank you very much for your attention, and I am ready to acknowledge your questions if there are some.
Thank you very much, Dr. Zamora, for your excellent lecture and your review on the dilemmas that our lupus patients face, cardiovascular issues, musculoskeletal issues, and very importantly, mental health issues. So we have some questions from the Q&A box. Not It's more than a few. So I will let's see what we can answer in our remaining the minutes that we have. From Dr. Rogelio Balagat, how would you stratify a lupus patient with active nephritis and on high dose steroids in the context of statin therapy? Moderate or high intensity statin therapy? Thanks.
Hi, Dr. Balaga. Thank you for that question. I would stratify the patient to high risk already because there are already several factors that increases cardiovascular risk aside from the disease activity. There's also high immunosuppression that the patient is requiring, and most likely all these would come together and increase the cardiovascular risk of the patient. So these patients, I usually start them on statins, and if I'm in doubt, I refer them to cardiology. So especially if they have nephritis, most likely they'll have hypertension. So we'd like to keep their LDL lower than 70. So yun yung parang what I do. But usually, especially if the patient can afford to see another specialist, I may refer them to a cardiologist as well. I
Thank
hope
you.
that answers your question, sir.
Thank you. Anonymous attendee, can a patient with SLE receive the COVID vaccine safely? I don't think this is a topic for today.
Yes, but I think it's something I can answer, especially if there are other people in the audience who are not physicians but are also advising patients regarding vaccination. Yes, in general, our patients with lupus really will benefit with vaccination because it's more likely that if you have lupus, an autoimmune condition, that when you develop COVID, your disease will be more severe. And the risk of vaccination, such as, for example, pain, some fever, and even if people talk about, or media has been highlighting that thrombosis or yung clotting, which is really very low in terms of incidence, it's still more important to be vaccinated because your risk of dying from COVID will decrease. Risk of getting infected and risk of dying. So in general, yes, but you will need to secure a clearance from your rheumatologist.
Okay, thank you. I'd like to acknowledge the presence in the group of the chairman of the Department of Medicine, University of the Philippines, Philippine General Hospital, Dr. John Anunuevo, and also to our colleagues from the Philippine Rheumatology Association. In fact, thank you for attending our session today, doctors. There was a question from Dr. Anunuevo himself. Is there a direct proven causal relationship between SLE and accelerated atherosclerosis? If there is it more of a microvascular problem than a macrovascular problem, meaning coronary arterial problem?
Okay.
Thank you.
Hi, Sir John. So it may not be a direct association, but yes, there is association. And in studies, it is really more of the microvasculature, which are affected in lupus per se. But we also have to remember that patients with lupus are also predisposed to developing antiphospholipids, which can produce thrombosis in the epicardial arteries or the larger arteries. So it can be both. That's why treatment of cardiovascular risk factors have been advocated for to help prevent organ damage and death in these patients, in the subset of patients.
Thank you.
Yes, sir.
From Mark Joseph Abaca. For patients who already have AVN, how do flares of SLE, how do you best manage flares of SLE? Are corticosteroids and immunosuppressants still used or recommended?
That's a very important question because I was actually asking myself that while I was making this lecture. And the answer is still yes, because lupus is still the primary condition of the patient. We have to manage the disease because it is what can cause further morbidity and mortality in our patients with lupus. But then yun nga, as we have seen in the slides, more steroids and more immunosuppressants are associated with avascular necrosis. So we may have to help the patient another way. Like, for example, for my patients with beginning avascular necrosis, but they have um, they still have disease activity, we talk about using a walker even in the house, trying to decrease weight bearing. So trying to help the patient in other ways. But we have to control the disease activity first and foremost because it can lead to further problems down the line if we don't.
Yes, thank you. I completely agree. In fact, the next question is the same. How do you manage, or similar, how do you manage lupus patients with AVN and new onset lupus nephritis? Do we proceed with MPP, pulse steroid therapy, and oral
Yeah.
glucocorticoids?
Yes. So I think the nephritis management takes precedence over the AVN because nephritis can kill the patient. AVN can cause pain, but it's something that we can also manage later on or help delay in terms of surgical management.
Thank you. Um, from Kiara UC, seems like that fibromyalgia symptoms such as fatigue and body pain coexist with lupus symptoms. How would you differentiate the two via testing? I think you answered this. When should I be concerned with the symptoms?
Okay, so yes, Sir Paulo, I was able to touch on that during the lecture, but to reiterate, there may be some tests that we can do. For example, we can check the CRP, which is inflammatory marker, or even the C3 to check for lupus activity and determine whether the symptoms of the patient are from lupus itself or from fibromyalgia. So
Yeah.
this is always a case-to-case basis. It will depend on the patient profile. And as rheumatologists, your rheumatologist will be able to help you out with that.
Thank you. And I think you mentioned the cell-bound complement
Yes.
activation products, which,
Too bad it's not yet here
yeah,
yet.
it's not yet here, but it would be
Sayang. But
good if maybe in the next generation.
yes, in maybe in a couple of years, hopefully we can have that.
Thank you. Good PM. Are there new updates on prostacyclin analogs for AVN? I think you also touched on this a little bit.
Yes. So these are your vasodilators that supposedly help increase blood flow in the bone area so that blood supply will be enough and necrosis can be prevented. There has been varying studies on this, and it's something we can use actually. It's just that iloprost is also not very it's not widely available in the country, but theoretically this is a good adjunct, especially if our patients also have other conditions such as pulmonary hypertension.
Okay. Thank you. Dr. John, thank you for another question. How common do we see patients with reduced systolic function primarily due to SLE? And what are the proposed mechanisms for it? It's a
Hi, Sir John.
difficult
Yeah.
one.
So I think sir, you're talking about for example, a patient has been seen to have low ejection fraction on echo. And I think this is already a complication of not just long-term lupus, but also of maybe traditional risk factors that the patient has. Maybe there is already hypertension from the nephritis. And this speaks of, well, sir, you're the cardio, nakakayang sabihin, but I think it speaks of coronary artery disease, whether in the microvasculature or in the bigger or epicardial arteries. And this may be because of like maybe an infarct or an ischemia, but also because these are people with lupus, we also have to determine if this is myocarditis, which is causing the decrease in ejection fraction or systolic function. And this is addressed in a separate or in a different way, because this would mean that we'd have to give higher doses of immunosuppressants or maybe entirely different medications for a patient. So we have to determine the cause, if it's myocarditis or if it's structural already because of a wall with, not very, which is not ano yun, hypokinetic na siya or akinetic na siya. So it could be any of those, sir.
Thank you. How frequent should we monitor the metabolic parameters screening for cardiovascular disease? For primary prevention, we advise starting lab screening at 40 years old, then annually thereafter. Is this more frequent for lupus patients?
I believe so. And in fact, if I remember correctly, we can start screening for, even in non-lupus patients, we can start screening for cholesterol and their sugar at age 25. So I hope I'm corrected if I'm wrong, but this is what I remember. So this is even earlier among lupus patients, and it's advocated for that we screen them right away once we are able to establish a diagnosis. So we have at least a baseline, and then we can follow them regularly. And it will depend on patient activity. Some patients will only need to see once a year. So maybe their lab test can be as less often as that, or even the intervals can even be longer. But some patients have higher disease activity, higher steroid use, so we may have to screen them more frequently. For example, sugar levels, because they're on high dose steroids. So it will differ depending on the patient profile. But yes, I agree that we can screen them earlier. Better if at the onset of diagnosis or at diagnosis.
Thank you. From Jason C, are there any safe and new updates on the medicine besides steroids for lupus? How can we reverse lupus if possible? Thanks. That's
There are
yeah.
already many medications that we can use, not just steroids, but your rheumatologist will always recommend the best one for you. So as much as possible, doctors really want to reduce steroids, no, among our patients. And we do this by using DMARDs or disease-modifying anti-rheumatic drugs, even biologic medicines. And close communication with your doctor is very important if you're a patient or if you're a primary care practitioner.
Thank you. Will early administration of bisphosphonates for SLE patients prevent avascular necrosis?
There are several studies which have shown that patients on bisphosphonates have lesser incidence of AVN, but at present, we do not advocate for using bisphosphonates for that reason. But we can always use bisphosphonates early, especially if our patients have risk factors of osteoporosis. We always have to consider the possible side effects of medicines before we start them on our patients. So their risk and benefit profiles should be considered.
Okay, thank you. Another question on COVID-19 vaccine from Rebecca Lorenzo Castillo. Which SLE patient would you not recommend a COVID-19 vaccine?
Personally, maybe none for me, no? Because if a patient is sick enough to be, on so many medicines for lupus, then that patient will definitely have a hard time coming out of a COVID infection. So for me, I believe I will even, I will recommend to all my patients with lupus to be vaccinated. I will just tell them that if their prednisone is high or if they're on immunosuppressants, then maybe the effect of the vaccine will not be as good compared with, for example, me, because I'm not on any of those medications. But some protection is still better than no protection at all. So this is in addition to their usage of masks and other precautionary measures. So I don't know, Sir Paulo, what about you?
No, I completely agree with you that we should really vaccinate
Everybody.
our lupus patients.
Mhm.
Um, and there's the issue about, well, we should just be cautious, and with if the vaccine is a live
Yes.
vaccine, which we stay away from a live attenuated vaccine. But for the current vaccines, I think they're all. I would recommend them
Yes.
to our patients.
They're non-active, non-live and inactivated. So
Yes.
the benefits would outweigh the risks. Even the risk for thrombosis, yung pinaka sensational the past week, no? As mentioned, the risk of thrombosis or blood clotting in that particular vaccine was 1 in 250,000 people, but the risk of thrombosis in patients with COVID na nasa ICU is 1 in 4.
Okay.
The risk of thrombosis in a person who is simply pregnant is 1 in 2,000. So it's really something that media has, unfortunately hyped up, and so it increases vaccine hesitance among patients.
Thank you. This I think is worth. No, it's a nice question, very practical. What should we avoid, like food, etc., that worsens lupus?
Um, in patients with lupus, whenever they ask this question, I tell them about alfalfa sprouts kasi yun lang naman talaga yung found to increase or possibly be associated with lupus. And what is alfalfa sprouts? I tell them it's this parang gulay siya na, parang herb yata siya na iniikot-ikot sa pizza in this certain restaurant. But it's not really very um, widespread. It's not very used much in Filipino cuisine. No? I barely see it as outside from that restaurant. But in general, I tell people with lupus and any chronic rheumatic illness to lessen their intake of fat and salt and sugar, because if you are inflamed, then this means your risk for cardiovascular disease is heightened, and lowering those products, yung fat, oil, sugar, and salt, will help you in the long run. Because I always tell my patients the most common cause of death in chronic diseases na in rheumatology is still cardiovascular disease. So yun yung kailangan nating iwasan, yung mga nakakasama sa puso. So same as with the general population actually. Other people ask about gluten, and gluten-free diet is very hard to maintain. Gluten seems to really promote inflammation in some people, but not all. So I tell them, if you want to lower your gluten in your diet, then I'm not going to, prevent you from doing that. But I don't want you to be stressed with your diet, trying to find all these gluten-free stuff and all these organic things. And this stress is what will drive your lupus to flare. So for me, it's really okay if you want to live a better lifestyle, if your food choices are healthier. But kung sobrang stressful to look for all these gluten-free things, then the flare that will come from your stress is not worth it. So kumain ka na lang ng tama or whatever you like, but in moderation, and just lessen your salt, sugar, fat, and yun. Yun po.
Thank you. I maybe two more questions, Dr. Zamora. Would you consider giving aspirin as part of the maintenance medications to lupus patients for as long as
Um,
they do not have contraindications?
Maybe not on a general basis, because it also has possible side effects such as gastric irritation. But in a patient with risk factors, for example, she has nephritis and hypertension, and especially if she has, for example, echocardiographic changes, or and especially if the patient has APAS or antiphospholipid antibody syndrome. And then even if that patient does not have any thrombosis yet, more likely I will prescribe it. But all of these are individualized therapy. So it will really depend on the patient. Some patient, mahapdiin yung sikmura, nag-ugib na before, had ulcer. So it's not something you'd want to give them. But it can be considered, especially if there are other um, reasons for giving it.
Okay, thank you. And one last question. Do you give statin outright for lupus patients with nephrotic range proteinuria? From Dr. Balagat.
I usually get their lipid profiles po, sir. And usually these patients are hypertensive as well. So usually my patients with these conditions would be on statins if there are no contraindications. I find that some of my patients develop myalgia with statins, so it's something that we have to consider again. But if their LDL is high or higher than 100 and they have these risk factors, I already start them on that. And if they can afford and if they prefer to see a cardiologist, I refer them to colleagues in cardiology just
Thank
for
you.
a better, management.
Thank you. I think we've really gone over time here. And uh, I there are a few more questions, but if you could just send your questions, we'll take note of them, and hopefully we can answer them at some other forum. So anyway, we'd like to thank Dr. Zamora for the excellent lecture. And just to give you a very brief summary of what she discussed, discussed the dilemmas of our patients with lupus, and three particular cardiovascular problems, musculoskeletal problems, and mental health issues. And for the cardiovascular issues, she focused on accelerated atherosclerosis, and we picked up that the coronary artery disease, myocardial infarction incidence is 2 to 10 fold, and these are young women, less than 55 years old. And I also picked up that the non-pharmacologic treatment. She mentioned some information on omega-3 fatty acids. You might want to consider that for atherosclerotic disease prevention. Um, she did talk about disease activity control, which is very important in for coronary vascular disease. And she then mentioned, discussed the musculoskeletal issues such as avascular necrosis and maintaining a high index of suspicion for this problem. MRI is still the gold standard. Treatment, unfortunately, it's still surgical, and there are a lot of experimental non-surgical treatments, but ultimately surgery might be the option. For fibromyalgia syndrome, it's a very common occurrence in patients with SLE, and differentiating between the two might be difficult, but it is a real problem, and we have to identify fibromyalgia and in lupus patients. And finally, for the mental health issues, stress, anxiety, depression, which are are increased in our patients with lupus, and more so now during this COVID-19 pandemic. So I think we've had a very fruitful discussion. Thank you very, very much, Dr. Zamora. And we'd like to thank again our sponsor, Viatris, and the Information Management Service Network team of the University of the Philippines, Manila, for the technical support of this webinar. And thank you, everyone, for joining us this afternoon. And we hope to see you all again for our next lecture in July of this lecture series. So thank you very much and have a good afternoon.
Presenting another chapter in celecoxib history. The Precision Ambulatory Blood Pressure Measurement Trial, a pre-specified sub-study of Precision, which prospectively examined the cardiovascular safety of long-term celecoxib use in arthritis patients with or at increased risk of cardiovascular disease. Precision ABPM was designed to look at the differential effects on blood pressure with celecoxib versus naproxen and ibuprofen. NSAIDs are useful for the symptomatic treatment of patients with osteoarthritis and rheumatoid arthritis. However, both non-selective and COX-2 selective NSAIDs have been shown to increase blood pressure or interfere with blood pressure control. "545 patients were randomized to receive celecoxib, ibuprofen, or naproxen. Patients had osteoarthritis or rheumatoid arthritis and required daily NSAID treatment to maintain their quality of life. In total, 444 patients had successful baseline and post-baseline visits at months 2 and 4. The two non-selective NSAIDs, naproxen and ibuprofen, were used at prescription strength. Baseline patient characteristics were similar among the three treatment groups. The mean age was 62 years, and the majority were women with osteoarthritis. Average baseline blood pressure was 125/74. And over half the patients were taking multiple concomitant antihypertensive therapies. A high majority of patients completed month 4 of the study. The primary endpoint was the change from baseline in 24-hour mean systolic blood pressure at month 4. Celecoxib demonstrated a mean change in systolic blood pressure of minus 0.3 millimeters of mercury from baseline, and naproxen showed a change of 1.6 millimeters of mercury, both of which were not significant. Yet ibuprofen had a statistically significant change with a mean increase of 3.7 millimeters of mercury at month 4. The mean reduction in the celecoxib group contributed to a significant difference of minus 3.9 millimeters of mercury between celecoxib and ibuprofen. There were no significant differences noted in the pairwise comparisons between celecoxib and naproxen, or naproxen and ibuprofen. Additionally, a post-hoc subgroup analysis was carried out to investigate the proportion of baseline normotensive patients who became hypertensive during the course of the study. Celecoxib demonstrated a significantly lower proportion of patients with new onset hypertension at month 4 compared with ibuprofen and naproxen. Since over 40% of patients with osteoarthritis also have hypertension, even small differences in blood pressure may impact cardiovascular morbidity and mortality. Precision ABPM broadens our understanding of the risks associated with NSAID use in arthritis patients with or at increased risk for cardiovascular disease.